Today, we'll talk about ultrasound, cardiovascular disease, and the tools you can use to track your own health. So, my journey's been pretty interesting. When I was a teenager, I broke my little sister's leg on a trampoline. We go to the hospital, we go to the ER, and they leave me in a room with all this cool equipment. And I got to play with it. They came back an hour later, and I played with the ultrasound, the fluoroscopy. I could see my fingers moving. I thought, this is the coolest stuff. I'm definitely coming back to this when I'm a bit older. So um, later on after college, I got a job with a guy who that was his thing, doing mobile ultrasound. The machines had become smaller, the machines had become mobile, the machines had become very portable. And offices, doctors' offices, wanted to have it in their office and not so much send it out. And somewhere around 2005, 2006, the ultrasound machines got really small. They became portable, like that one under the screen. Small enough, useful enough. They can look at hearts, they can look at abdominals, they can look at all these things, but they're just not common enough that they're in everyday practice. So this is what you see. These ultrasound machines, they're useful, they're great, but the new ones plug into your cell phone. They're digital. They can see every part of the body. The bigger ones, I need a different ultrasound probe for every part. I need for your heart, I need one probe. For the belly, I need another probe. It's a lot. But the digital probes, man, they can emulate. You can look at a pregnancy 1 minute, the next patient, you can look at the AAA. You can look at it's just awesome stuff. I deliver beautiful reports to clinics and doctors all around the country. This stuff is still a little bit too nebulous. It's too much in research. It's not used enough that it can be used in common practice. So I scan, I educate doctors, I tell them how to do this so that they can help patients understand. Just looking at your arteries, once you understand it, see it, you get an intuition for what's going on, 50% of your patients will make better decisions. They'll reduce their risk of heart attack and stroke. They'll eat less sugar. They'll be kinder to the neighbor, but they do reduce their risk 50% over the next 12 months just by making better choices. What do I look at? In the artery, there's layers. The layer that touches the blood is the intima and media. It is alive, it breathes, it exchanges nitric oxide with your blood. That is the molecule used to tell your vessels to dilate for exercise. Your vessels need to dilate to get more blood around, for reproduction, for lots of purposes. But when it's compromised, it doesn't work so good. The layers of the wall flex. With every heartbeat, they flex. When the walls become thicker, they don't flex so much. Also, something that's not commonly proselyted is there's turbulence in the blood. At every junction, there's mild turbulence. So if you did have dense LDL particles, if you did have sticky cholesterol, if you did have LP little a, I see symmetrical plaque on both sides of the patient's arteries because that's an inflammatory molecule that gets burrowed into the wall. And we'll end on that subject in a little bit. So what can I see with the ultrasound? I can see atherosclerosis. That's the plaque building up in the arterial walls. I can also see arteriosclerosis. That's the thickening of the walls, the less flexibility of the arteries. Inflammation, arteriosclerosis, seems to be more of a metabolic issue. Too much sugar, too much insulin causes that inflammation. Going back one slide, the plaque seems to be more of a small molecule disease, getting burrowed into the wall of the artery. The body doesn't have a good expulsion program, so those plaques will form, they'll build up. In Vietnam, we got a bunch of cadavers back, and they were able to find fatty streaks in these young men, teenagers, young 20s. Because of the stress, because of the diet, we were finding the beginnings of this disease. In the 1980s, NASA got a hold of this, and they figured out that these markers get thicker, get worse as the inflammation goes on. So how predictive is this information? On the highest level, this is a study with 10,000 people over 10 years. And at the end of it all, they put all the patients into categories. Bottom right, category 4, 381 patients had 50% stenosis or more, that much blockage. And I see this every day. We had a couple patients in the last 24 hours that were 70%, 60% occluded. Anyways, 81% of these patients had a heart attack or stroke in the next 10 years. The next category up, 239 patients, 40% of those patients had a heart attack or stroke. They just had inflammation, not significant plaque, but their walls had a diffuse thick coating all over it, like on the bottom left. But you can see the levels. A little bit of a plaque gets bigger, or you can have diffuse thickening everywhere. Patients who see this on their own arteries make so much better decisions. So how do I relate this to you? I've built a report, I've put it all in sections, and I use references to try to let you know what's normal, what's not. The first thing I look at is that inflammation, the lining of the artery, where that box is measured on the right side. That's intima and media. I give you a measurement in millimeters. Always, almost always, less than 1 millimeter is how thick that lining is. And I'll give it to you in a vascular age. I'll reference those big research studies so you can see what the measure of inflammation is. Vascular age is just inflammation. The plaque is a different animal. The plaque is the burdening of the arteries, those blisters, those plaques forming. On the bottom left, you can see some very small plaques forming on this patient. On the bottom upper left, this is diffuse, thickened intima. All of this is over 1 millimeter. This patient's artery doesn't flex very well, doesn't move very well, it's not very responsive. Guy probably has erectile problems. Also, up here you can see a big soft plaque. How do I know that it's soft? The blood is dark. The liquidy parts of the artery, the liquidy parts of the body are also dark. If this were a calcified plaque, it would be very bright. I would be a shadow underneath it as the ultrasound can't see through calcified areas. This is a slide taken from a research study, rosuvastatin, I believe. On the upper left, you see a plaque. As time goes on, this plaque is shrinking. You can see these pools inside the plaque, these cores, these liquid cores becoming more calcified and secure as time goes on. At the end of the process, you should have a plaque that's shrunk quite a bit. Patients ask me if they disappear. They do not disappear. They will shrink 20, 30%, but they will always leave a scar, a very calcified scar. In fact, on your gross anatomy, when they take these plaques out of cadavers, they snap. It's a visceral sound. It sounds like chalkboard chalk. Your body did that. It will secure the plaque by calcifying it, loading it up with calcium. So what changes do these people need to make? They need to starve their body of things to make plaque with. So here's where you're going. Too much sugar, too much insulin causes inflammation. Too many atherogenic particles, such as tobacco, such as seed oils, which are deep fried, are not very good for us. And Lp(a). These markers get stuck in the walls of the artery through the gentle spinning. The artery has to be compromised a little bit. The glycocalyx is a layer that we'll talk about at the end. It's a layer at the very touching the blood. It's got little hairs and it moves along. And these soft plaques are very dangerous. If I can find a plaque in your neck, there's a 60, 70, 80, 90, depending on the research study, that a similar size plaque will correspond to the coronary tree. If I can find it in your neck, it is also in the heart. And it's not that your body clogs off. You don't go 70, 80, 90% occluded and then it stops. Your body, these little tiny plaques will pop and rupture. And when that goo hits the bloodstream, it turns into a giant thrombus, clot, or wherever. So if it goes up to your brain, that's a problem. If it goes down to your legs, you get the red puffy legs. You get those, and we need to look at them. But if any of these clots go to a single point of failure, such as your heart, your brain, you've got much bigger problems. These are some examples of what's good and bad and what we see every day. Upper left is reasonably good, healthy, thin lines along the arterial walls. When they're healthy, they look like they were drawn with a mechanical pencil. As they get older, they get thicker. This upper right is a very complex plaque. This center very bright spot is calcified core, but this person's body kept generating more plaque. And over time, you can see more forming in different consistencies inside. This very bright area is very calcified, but it does not leave a shadow. Ultrasound cannot pass through calcified structures. The bottom right is an example of an artery that goes up to the brain. and you can see this big plaque sitting on the wall. This is a soft plaque. And on the left side, you can see a top-down view of that very same plaque. It measured at 55% stenosis. We use the blood to show where blood is showing, where it's not showing, and we move back. So how do you get your body to calcify a plaque? The calcification is the body's defense mechanism. For unexported babies, the woman's body will calcify it. For foreign objects, our body will load it up with calcium. There's an exchange process. Outside of the vessel, there's no expulsion inside the artery. It all happens to the outside. So the body will not send that plaque back into the blood. Little blood vessels come in from the outside called vasoviscorum. They're microtubules, and they will bring calcium into those plaques. Now, human cells don't like crystals. They break the cell wall, they hurt, they cause problems. So plaques are problematic because there's no healthy tissue around it. You get calcifications, you get jagged little edges, and it's just not going to be an adversary in the long time. How much plaque do we find? If I were given a patient population of 100 patients and I scan them all in a day, about 20 of them would have 30, 40, 50% blockage. About 10 of them would have significant blockage, 50% or more. You do want to know that your vascular surgeon doesn't want to see these patients until they're 80, 70, 80, 90% occluded. Now, personally, if my artery were 30% occluded, I would want to know. But the hospital and like most organizations will say that's normal to mild. If I'm trying to prevent a heart attack, that's a big deal to me. So knowing what's what in the hospital world versus in the prevention world, how does that work? Now, let me show you one of the reasons a plaque forms. Blood comes up the main artery and it splits into two pathways. Red is blood going up to the brain, going up to the nose and face. Blue, here on the bottom part, is blood that gets caught and there's turbulence, there's backflow. So in this little section right here, if you did have these dense atherogenic particles, they get pushed into the wall every heartbeat, every day. Gentle, slow irritation will cause plaques. The most common place for me to find these plaques is in the bifurcation, right before they split into two pathways. Now there's things you can do. Diet, exercise, of course. There's also layers we're learning about in the blood, or in the vessels. So touching your blood, on top of the intima and media, those layers that I measure, there's little hairs, cilia-like hairs. They blow in the breeze. They're negatively charged, so they don't stick to the blood. Too much sugar, too much into metabolic problems will wear down this layer. You can see on the right side how worn out, like we're walking on grass too much. Recently, there's been a nutraceutical that lays down on top of this, like it is a seaweed, and microscopically, it looks a lot like those hairs, and it allows this layer to grow back. This layer disappears on some patients when they've had too many problems, too many metabolic problems, and we can allow it to grow back. So clinically, who are the patients that I usually see? Blood pressure, diabetes, 1 or 2, metabolic problems, sugars, cholesterol, family history. I don't know, I just felt like my wife should have sent me in here. These are all valid reasons. Patients that we can show this to make better decisions. Patients that understand this process, patients that they're more aware of what's going on in and out of their bodies. So Vasolabs is a national group. We deliver this report to clinics, heart attack and stroke prevention specialists, hospitalists. I do want you to know that people who truly do prevention are rare. A lot of people say, let me ask my cardiologist. Cardiologists, great guys, great trade. They stent, they open your arteries up, but they don't really have preventative therapies. They don't have preventative program. I don't see a lot of them. If you're lucky, your cardiologist group will have a nurse practitioner or somebody doing the prevention, but it's not the aim of your medicine. You're going to be the only advocate for yourself. And these tools, they're able to help you quantify your arteries, help you improve your arteries, are all here at your disposal. Thank you very much.